Hello and welcome to our webcast. I'm Cole Mertz with Moss Adams, and I'm going to be getting us started for today's session, Denials Management, an Integrated People's First Approach. Before we begin, I'm going to play a brief housekeeping video.
Welcome, and thanks for joining. We're pleased to present our continuing professional education webcast series. Before we begin, please keep the following in mind. You can customize how you view our presentation and interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can adjust window size and placement or enter full screen mode using the controls at the top right of the window or dragging the bottom right-hand corner to resize. At the bottom of your screen, you'll see a series of icons that relate to a different aspect of our session. You can download a PDF of today's slides from the Slide Deck and Handouts widget. You can ask questions by typing in the Q&A window and clicking Submit. We'll do our best to answer all questions or follow up via email. If you experience technical difficulty, refresh your browser by hitting the F5 key. Today's session offers 1 CPE credit. To receive credit, you must meet the National Association of State Boards of Accountancy requirements. You must attend at least 50 minutes of the session and respond to at least 75% of polling questions. To participate in the polls, please check the button next to your answer within the slide window and click Submit. We'll track your progress and alert you when you've earned CPE credit. You can then click the certificate icon in the CPE Progress widget and download your CPE certificate. Don't worry if you can't download your CPE certificate today. We'll email you a copy in 2 weeks. If attending this webcast in a group, you must complete our group CPE attendance sheet, available in our slide deck and handouts widget to receive credit. Please have all group members sign it and send only 1 sheet per group. CPE credit can only be awarded to participants registered as themselves and isn't available for participants who view the on-demand version. This presentation is not legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances.
And now I would like to introduce today's presenters, Richard Riter, Director within the Moss Adams Revenue Cycle Practice, and Erin Ressler, Director within the Moss Adams Lean Healthcare Practice. Their bios and contact information are located in your webcast console for your convenience. And now I would like to turn the floor over to Richard to get the presentation started. Richard.
Thanks, Cole. Hi, everybody, and welcome. I'm Richard Riter. I lead the Moss Adams Revenue Cycle Consulting team. I'm joined today by my friend and colleague, Erin Ressler. She's a healthcare industry leader in lean process improvement for providers. We've both been in the trenches doing this work for over 25 years. Really appreciate you all turning in for this discussion today. We're going to focus on our approach, which relies on both empowering people and using technology effectively in the denials process. We both feel really strongly about the importance of helping provider organizations improve their rev cycle performance in a long-term, sustainable way, built on a foundation of respect for the people who are actually doing the work. So the agenda we've got today, we're going to talk through the background. We'll talk about what People First Denials Management actually is. We'll talk about some of the benefits of the approach. We'll talk about how to get started. And then if we have some time at the end here, we'll do some Q&A as well. But first, we wanted to start with the poll question. Cole?
Sure. The first polling question is now up on your screen. We'll give you a few minutes to respond. Please click the radio button next to the answer you choose and hit Submit. If you can't see the Submit button, please enlarge the slide viewing area. For our first question, we have, what is your biggest revenue cycle challenge? A, staffing, B, technology, C, payers, or D, other challenges? Give it a few more moments here. I'm going to go ahead and close the question now. All right, Back to you, Richard.
All right, thank you, Cole. Yeah, so this is definitely in line with what we're seeing out there. Is staffing and technology are definitely issues, but the payer behavior is just continuing to shift, and we'll talk about some of the costs of that here as we go through. But it really makes it tough to stay on top of things when it's a moving target like that. So thanks for the survey results there. All right, so first we'll dig into some of the background here and just kind of where we are as an industry. I think we've got these converging challenges that we're all facing, and I don't need to tell, I think, all of you in the audience, what some of these challenges are, but just to highlight some of them. So first of all is increasing denials, and it's not just all of our imagination. The numbers really do bear this out. The denials have increased over the last several years. We've seen them increase from about 9% in 2016, by a third up to 12% here in more recent data. That's combining with some of the margin pressures that we're seeing. Historically, we've seen hospital margins in the 2 to 5% kind of range, and that's now down below 1.5%. That's really not sustainable, and so that's creating a lot of other pressures that kind of trickle down through the denials process as well. From a staffing standpoint, it's been really tough to find and retain people in all roles, particularly within revenue cycle. I think we're seeing the rise of remote work means that people can find roles anywhere they want to, and they are doing that. And so that's definitely been a challenge from a revenue cycle perspective. And then, getting to the outcome of the poll that we just saw, payers really are taking advantage of a lot of the latest technology, a lot of the AI and machine learning tools, and payers are ahead of providers on this. And I think providers need to kind of catch up. And it's making providers be a little bit off balance from a denials perspective. What are you saying with your clients, Erin?
Yeah, I would say the same thing. In fact, the denial rate, I'm hearing rates now up around 14, 15, 16. So just the point is it's always increasing and it's just getting worse. And the staffing shortages is definitely something I'm hearing a lot as well.
Awesome. Thanks, Erin. Yeah, it's definitely, this story is not over by a long shot. It's definitely, I feel like we're kind of in the first bits of it here still. So thinking about some of the details within denials, if you look at that bottom left box there, you can see fewer than 20% of denials are completely avoidable. And I think that's really the take-home message here, is that especially if we work in advance and try to prevent a lot of these denials, we really can do that in a lot of cases. And then looking on the right side, what we can see there is we can see that denials are coming from functions throughout the organization. About half of them are coming from front end. A lot of them are coming from back end, from the care delivery and documentation sites as well. And what that means is that in order to fix this, we have to actually work across the organization, which in a lot of healthcare organizations is really challenging to do. What is switch gears a little bit here and talk about digital transformations. And I think nobody starts out with some big initiative expecting to fail, right? We all expect to get the benefits that we're aiming for. But the fact of the matter is that most transformations don't actually get there. And the good news is that for those of us who kind of study these things, there are some things that you can do to try to beat those odds. And you can see them here on the left side. The first is it's kind of a top-down, which is putting the right leadership in place and having really strong program sponsorship. The next one is building the capabilities of your teams. That's kind of bottoms up, making sure you've got a really strong team. The third one, involving the people who do the work in every stage of development. So that helps not only with buy-in as you're going through the process, but it actually kind of helps make sure you're taking everything into account as well. These are really complex processes. And the fourth one there is developing a good understanding of the underlying process, integrating technology where we can. And generally within denials, the areas where we see technology benefits is kind of generically related to some kind of connectivity to payers and things like that, insights development, and then automation. And because automation is so important within denials management, we wanted to highlight some of the areas where technology can help with automation. And generally, we see those in the projects we do with cost savings, with staff focus, so they can actually focus on the things they need to focus on instead of doing things that could be automated, with kind of forcing some of that standardization and consistency, reducing errors, and then a lot of times you can kind of build in tracking and accountability into the tools as well. So that's really how we find automation can be really beneficial in this environment. All right,
and with that,
Cole, next poll question.
Great, thank you. For our second question, we have, in what areas of the revenue cycle have you had the biggest challenges implementing digital or tech solutions? A, patient access, B, charge capture or coding, C, billing or claims scrubbing, D, denials, or E, we have not attempted to automate our revenue cycle. And as a reminder, if you'd like to receive CPE credit for today's webcast, you will need to respond to at least 3 of the 4 polling questions. Please make sure that you are selecting the answer choice within the slide window and not adding to the Q&A window. Give it a few more seconds here. All right, I'm going to close the poll and back to you, Richard.
All right, thank you, Cole. Yeah, and again, this is really consistent with what we've seen, which is, denials is really challenging to implement some of these solutions, along with charge capture and coding and some of the other areas. So yeah, really appreciate your responses on this one.
All right,
Erin, do you want to talk us through the kind of overall approach?
You bet. Yeah, that last poll, just really interesting that I've seen a lot of efforts also to involve AI in the pre-auth process. That's something that I hear quite a bit. And just another couple of comments on the tech, the digital side. It really relates to, I'm just going to go back here to our people first approach. I think that applying your tech in the right way, right? What can we automate? If we can automate stuff that people are having to do right now that may be taking down their job satisfaction a little bit, that repetitive stuff, that ties right into the people first approach, because we want to talk, and we'll talk a little bit more about this later, but how are we really utilizing them to their potential and really enabling them to bring their creativity to bear, or bring sort of their cognitive abilities to bear. So I really like to kind of dig into that data. So more about what do we mean by people first approach. So on your screen, you see what we kind of affectionately refer to as the usual suspects. So there are a lot of areas in the revenue cycle that we can look at to try and get that denial rate down. And we've kind of grouped them into 3 sections here. So you have business processes. So looking at our denial response. So how quickly are we getting back when we do have a denial? How fast do we know about it? How fast are we able to appeal it? What does our payer collaboration look like? Are we in fact collaborating? Are we reaching out where we can to try and get those negotiations going? And then you have kind of a bucket that we call data and technology. So do we have good KPIs in place? Do we have a dashboard in place that alerts everybody up and down the line, from your patient access folks all the way down to your denials and billing folks, what the status is of our denials? Do we have some kind of an early warning system? Is our data and technology serving us to give us that early warning system that maybe denial patterns are changing, and can we get a jump on it? And of course, the use of AI. And then the third bucket there is very important, obviously, people development. So do we have good education for the clinical and front end staff on all of those changes going on in payer behavior and policies and procedures and all of that? Do we have problem-solving capabilities built into our staff? Do they know how, when there is a problem or a defect, do they know what to do and how to stop the line to solve that problem? And what does our reward system look like? So all of these are worthy and important, and people are working on different pieces of that at different times. But really the point here is we need to think about a holistic approach, because all of these things need to work together. And we'll show you a little bit later on more about what we mean by systems thinking. But if we have more of a systems thinking approach, then we can be more methodical and thoughtful about how we approach these things. And again, and you'll hear us say this, but it really kind of starts with your people, because they know where the problems are. Anything to add to that, Rich?
Yeah.
Yeah, and I mean, what I would add is from a data and technology standpoint, a lot of times what I see is either providers have one or two of these things covered, so they've got some denials response infrastructure in place, or they've got maybe some KPIs and a dashboarding, but they usually don't have all of these things covered. And the other thing I see within the data and technology space is they'll put some of these tools in and they expect a lot more out of them than they're actually able to deliver. And so, you really do need this kind of comprehensive approach in order to get the results that you're looking for.
Totally agree. Thanks, Rich.
All right. So now we're going to run through kind of what our methodology is. And our methodology starts with the financial sustainability goals of the organization and your technology strategy. And, we really want to focus on starting with kind of where you are as an organization, kind of what your technology strategy is. And that's important here because we want to plug in kind of where we can to the technology you've already got in place. Also, we find some organizations that really are, their goal is to be on the cutting edge, the bleeding edge of technology. And so we want to support that where that is the goal of the organization. Other organizations say, you know what, let's kind of stand back a little bit. Let's let others beat that path and kind of make the mistakes and things, and we'll see what works and what doesn't work from them. And so we want to make sure that we're taking advantage of whatever technology strategies in place. And then you can see the 4 phases we've got to our approach. So it's diagnose, and then this rapid iterative change, stabilize, and spread. And then within each of those, the diagnose phase is obviously where we start. And so, first of all, we want to make sure we're understanding denial performance and recent changes. And, one of those surveys around kind of, what are you seeing as challenges? And the overwhelming response was payer, changes in payer behavior. And that is undoubtedly one of the huge challenges we're all facing today. And so that's really where we start is, not what was happening 2 or 3 years ago, but what's happening right now with denials performance and what have some of the recent changes been. Secondly, then we'll develop a data source of truth. And one of the things we find at so many clients is that there's not actually agreement on kind of where we are from a denial standpoint, looking at metrics and things. And one side of the organization will think that, hey, we're in pretty good shape. The other organization will feel like it's kind of the opposite of that. And so really starting to get everybody on the same page around what the data source of truth is really important in this diagnose phase. And then involving the people who do the work. Again, they're the ones who really understand it, who know it, and who are going to have to take this forward. We want to map the process, and then we really want to understand the context. Are there other things going on within the organization that are going to impact all this? Are we combining business offices? Are we building a new wing on the hospital? What are all the things that are going on that are going to impact this work? And then we move on to this rapid iterative change. First of all, we want to deploy quick fixes wherever we can. We want to get quick results. And we do that using these rapid test cycles, evaluating the results, and then kind of seeing what works and incorporating improved technology as we go. We also want to teach standard tools and then test out that standard work as we go. And then moving on into the stabilized phase, we're going to develop data and reporting for monitoring and also early warning. So many cases we see the first warning of denials issues come in the financial statements. We see the revenue deducts increasing or something like that, and the CFO says, "Hey, what's going on? Why is my revenue down this month?" And 3 weeks later, somebody's dug through it. They say, "Oh, it's because our denials increased 4 months ago, and now we're finally seeing the results in our financial statements." Right? We want to have kind of the opposite, where we know very quickly and we can be on top of it, and we can address those issues before they manifest themselves in the financial statements and cash flow problems and all the rest. We're also coaching leaders and problem solvers. So again, kind of the top down and the bottom up from a skill set standpoint. We want to teach systemness, and then the culture change piece of it is just absolutely critical for making this all stick. And then from a spread standpoint, we start to deploy standard work kind of everywhere that we can, everywhere that it makes sense. We develop infrastructure for continuous improvement, and then we really build routines around daily management. What else would you add to that?
Yeah, I think that's good. The phases are pretty much the same no matter what the problem is, which is one of the things that's nice about this approach is it works on pretty much any of the problems that you're seeing. I would add that in that second phase, the iterative change phase, there will be quick fixes, but one of the things that the team is tasked to do in the diagnose phase is to also identify fixes that may not be so quick. And so there will be ongoing improvement, right? We're going to teach a team how to sort of Pareto out the opportunity based on potential impact, based on resources required and all of that. And in that, we also teach the team how to measure the basic tools of measurement and plan, do, check, act. And so they start to understand early on the importance of run charts and really tracking your results. And moving through the stabilize and spread phases, more and more people will become parts of those improvement teams and will start to adopt that. So that measurement piece is going to become a really important part of the culture as well. Okay. So a little bit more about what do we mean by this people first. So talking about the first phase we mentioned there, the diagnosis phase, the first thing we want to do is using the data is using the denials data is really to do a deep dive and figure out where is the opportunity. So using some Paretos, sorting out those denials by payer type, by payer, by code, by patient type, and just look and see where the opportunity is, both in volume of denials, value of denials, that kind of thing. And that will help us sort of scope the work and figure out where do we really want to dive down. And the next thing we need to do is bring together a cross-functional team of folks from all parts of the revenue cycle. So some folks from your patient access area, folks who will work at the call center who take in that information, folks on the back end from billing who work the edits and work the denials. Bring them together and have them actually go see each other do the work. This is a really important part of the diagnosis. So we'll have people from the call center go watch other people at the call center do the work. And we give them, you can see some examples here of tools that they use to observe. There's very structured instruction that we give them on how to observe somebody doing their work. And we'll have somebody from the denials space maybe go watch somebody do pre-auth, for example. So that's a big piece of this is first people need to go see. And then the next thing that they do once they've done that data collection and that observation is they come back and we go old school. We get some Post-it notes and they get together and they map out the flow of a claim. They may not be going to every single part of the revenue cycle. The opportunities of the client may not have shown that coding is a big problem, so they may not map that. But the important piece here is that all the parts of the revenue cycle, the folks involved are working together to put that whole picture together with the Post-it notes that you see there. And they learn where the defects are that are causing these denials that are flowing downstream. They'll see the problems in the handoffs. They'll see those glitches in the software that are allowing us to enter free text fields when actually it should have been required, things like that. And then we'll help them learn about problem solving and Paretoing down and figuring out what are the rapid changes that we can start to move into the iterative problem solving phase with. So a little bit of a mix of the diagnosis and problem solving here with this team approach. So a little bit more about the systems thinking. So why is it important that all people involved in the rev cycle understand the whole process? So if you imagine a patient on the left and the claim is sort of starting, right, when they first contact us, show up at the emergency room or make an appointment or something like that, and you see the buckets there are kind of your basic rev cycle buckets, right? So they go through some sort of scheduling, registration process, might be some pre-auths needed, they do a check-in process, have their care event, and so on down the line until you have closed the account. And so you want that to be a smooth flow. So you want the patient and the claim, right? We want their physical health, but also their fiscal health to have a happy patient. We want that flow to be smooth all the way down the line. But what we really end up seeing is kind of this, right? We have a lot of silos going on. And so not a lot of communication up and down the line. We may even in our organization be trying to do some formal improvement in one or two of those silos. So there may be improvement work going on in the scheduling pre-reg side. Maybe at the call center, the queues are too long. Or there might be improvement going on down there in patient accounts. You know, again, we're not managing the queues real well. We've got defects piling up that we can't get fixed. And so we might be working there. But if we are not looking at the whole, we may end up optimizing one of those functions to the detriment of the whole flow. And so that's one of the things that we're trying to teach the folks doing the mapping is to understand that the importance of understanding the whole flow is really important. So, and the other thing that could happen here is, what if you have solved a problem on the front end there in the scheduling pre-reg with some kind of a tech solution, and now it's locked in, and then you come to find out that it actually had a negative effect downstream, and now you're locked in. One example I can give of that was I worked with a group of people who, when they actually went to observe each other doing some of the data collection on the front end, they did in fact find out that some of the data fields where they were supposed to be entering data were free text and not drop down. So it was kind of garbage in, garbage out, right? And that was flowing downstream. And then they had some fields that should have been required fields that they were allowed to skip. You want to think about how can we get rid of all those walls. So then what differences do you see here, right? So we have all of the staff teams working in their different areas, but we now have a little bit better information flow up and down the line. We're going to work on building in some measurement systems and visible metrics so that everybody understands the status of denials and the status of the revenue cycle at any given time. And most importantly, you see on the bottom there, those feedback loops. So you have the reporting from the back end back to the front end. If they start seeing defects in some sort of registration collection process or insurance collection process, they can feed back to the front end real quickly. Hey, we're seeing this go sideways and we can do something about it. So it's that the systems view of the whole thing that we believe is really important. And we try and teach that to the team with the value stream mapping. So as Rich said, when the team has done their mapping and they've identified lots and lots of opportunities, they will see some quick fixes. We actually would run them through an exercise where they brainstorm improvements and come up with all kinds of improvements, and it varying in complexity from simple and quick to a little bit longer term. So we need to Pareto those out, right? Where do we want to go first? And what we mean by quick fixes is oftentimes they're discovered by the team without us ever even having put those things in the scope for the team to look for. So three examples are given you there that we've actually seen happen. So in one of the clients we've worked with, the billing and accounts team had no idea until they had one of these mapping events that the front end departments, the clinical departments, were not getting any reports at all of defects and denials. And so they instantly put together very quick and simple reports and started sending those back upstream every single week to all the clinical departments. And without any other changes, those billing defect rates started to plummet without even changing the workflows. Second example there, client B. The team did not understand that there was such a long lag time between the date of service and encounter submission. I think they were submitting once a month. And when the team got together and saw that, they went, gosh, why aren't we submitting more frequently so that we can find out if there's a problem sooner? So they increased the frequency with which they were submitting those encounters. And then client C, this was less about denials, but it was also one of those ahas. They had a duplicate chart problem. And when they went to observe the front end folks, they found out that those folks had no idea how not to create a duplicate chart when somebody would call in for an appointment. They didn't know how to look up the patient correctly. So just all kinds of quick fixes that don't need a whole lot of resources to fix or a whole lot of time to fix. So anything else you would add there? One more thing I will say too, just to emphasize, we would be teaching, or the team needs to learn how to measure and how to report the process health at all times, right? So that needs to be built in so that there's monitoring going on at all times. Just run charts or simple graphs of how defects are doing or whether standard work is being followed. So that's a big piece of this as well.
All right. Next up, we're going to zoom out a little bit and talk about this sort of conceptually, what we're doing. First of all, the process here, it forms the foundation for everything else, right? So we want to have a process that's consistent, that's predictable, that's oriented toward the financial outcomes that we need as an organization to be sustainable, toward staff satisfaction and patient experience. We want to target those high value items first. Erin was just talking through kind of how we do that and how we get some of those quick wins in those high value areas. We also want to make sure we're baking in that information flow right from the beginning, right? It's tough sometimes to build that in after the fact. If you already have a process in place, it's a lot easier to build it in at the beginning. And then from a technology standpoint, first of all, what we want to be doing is we want to be kind of weaving in and optimizing any existing technology that's in place. First of all, and then kind of what we want to look for in terms of functions of technology. We want to be facilitating workflow. We want to be automating simple and repetitive tasks. We want to be obtaining insights into changes in payer behavior. It's a constantly moving target. We want to look at our internal processes, and we want to have some of those early warnings that Erin was talking about. So if things do run off track, we want to learn about that really quickly. And then we also want to have really seamless communication with payers. From a people standpoint, rev cycle is kind of a funny space where, if we go back several years, revenue cycle was not always really very well respected, and it wasn't really necessarily thought of as a desirable job. I think that's changed somewhat over the last several years, but it still can be a challenge, and we really want to build on that improvement of kind of how people think about revenue cycle jobs, is thinking about them as good jobs, and this being a sought-after place to work. Because this approach relies on a much more highly skilled workforce, it's really essential that we're attracting and retaining people who are invested in learning and problem solving. And you can see the items down here about kind of how we go about doing that, right? So kind of making sure we've got a team that's kind of well compensated, where they've got a schedule that makes sense and works for them, data and technology enabled, so they have the tools to do their jobs, they've got the training to do their jobs. And then to kind of build on that for high performance teams, have folks who are empowered, who are committed to the organization, who really understand how to problem solve, and we've got kind of a common language around how to do that. They're making their full use of skills, and then they want to have a career path that makes sense for them, right? That's going to be different for every person, but that's really the goal there, is to have a kind of an individualized career path. Looking at the culture side of it, I think the most foundational piece of culture is trust, and how I think about trust is it needs to go both ways, right? We need to have trust in our people to do the right things, and their people need to be able to trust the organization as well. And so that's really the first part about, from a culture standpoint, how we think about things. Most of us got into healthcare because we like the mission of it, and we need to really take advantage of that and nurture that and not lose that through these revenue cycle changes. If you think about who has contact with patients in an environment, of course, there are a lot of contacts, really important contacts that patients have with clinicians and other folks on the clinical teams, but really more contacts often are had with revenue cycle people than anybody else. And if you think about some of the outside of your job, kind of your personal life, some of the organizations you might deal with, whether it might be the cable company or your cell phone company or something like that, and you think about, are those positive interactions you have or negative interactions? Do they make you want to have a continued relationship with that organization or not? And I think the question answers itself, right? We definitely want to have folks doing revenue cycle work who are very positive about the organization, who understand the organization, who are invested in the mission, right? And that's really a lot of what this culture is about. Continuous improvements. They need to have the tools and not just the tools, but actually the ability to do continuous improvement as well. And then focusing on the overall system. Erin talked a lot about that. And then looking at people as an asset versus a cost. I think that's really fundamental here, is that our people are the most valuable thing that we've got in place, and we need to really appreciate them that way. All right, and I think we've got a polling question up next, right, Cole?
Yeah, I will push it live now. For our third question, we have, are you currently using robotic process automation, RPA, or artificial intelligence, AI, for denials management? The answer choices are A, yes, and it's yielding significant benefits. B, yes, and it's providing some limited benefits. C, yes, but it's still too early to determine outcomes, and D, not yet. Give it about 15, 20 seconds for y'all to submit answers. And as another reminder, you must answer 3 out of the 4 polling questions to receive CPE for today's webcast. Give it about 5 more seconds here. All right. Back to you, Richard.
All right. And thank you, Cole. And, I think this really shows, again, the competition that providers are having with payers. And right now, payers are on the leading edge of that, unfortunately. So this is what we're seeing is, payers have put in a lot of technology and things that providers have not yet gotten to. And so, really what we're talking about here is making sure that the providers have the ability to do that and that we're integrating that in a really effective way into their operations.
And I'll just chime in here, Richard. I think for me, that brings up the issue of if we're going to deploy tech or AI or some sort of technical solution, have we really understood the process first, right? So one thing that we see often is an EMR rollout is a good example. There's some effort done to sort of figure out what are the modules and what are the screen flows and that kind of thing, but not enough work is done, again, going to observe the people doing the work to ensure that the tech serves the people rather than the other way around. So on one hand, I'm glad to see that not everybody has jumped on the tech bandwagon, because you may be wanting to understand your processes a little bit better. But when you have the people go observe the work closely, you will find things that will make you think a little bit differently about what sort of tech solution that you need, or gee, maybe we need a different screen flow here. So that's a mistake that you want to try to avoid, because it's pretty expensive then to undo what you've already put in place. So thank you for that poll. So again, what makes this approach better? So just to kind of summarize, so I really like this quote, and actually this came from Rich. I think the right thing for your people is in fact also the right thing for your organization. Respect for people is a foundational element of any quality program. Your people know where the problems are, that you just need to go ask them. And the people closest to the front lines will tell you, and you will learn a lot from them. Up and down the revenue cycle, everywhere that work is done. Your people who do this work every day and know where the problems are, they will be the ones finding and fixing the issues. Those are the people that are going to be in the room mapping out the process and seeing where the handoffs are not happening, seeing where there's problems with the data fields and such, those kinds of things. And they can help design work, and Rich alluded to this a little earlier, that they enjoy a little bit more. So that they're not coming to work feeling like I just have to deal with these defects all the time and queues I can't handle, and I just have to kind of slog through it. They have a little control here. They can create standard work and flows that work for them. And that's a very people first way to look at all of this. So they can help design work they enjoy more and that challenges them and that they're a little bit more invested in. And I just like this quote on the side here: on good teams, coaches hold players accountable. On great teams, players hold players accountable. So you've got the front end folks can talk to each other and say, what can we do differently? This isn't working, right? So people first approach, real important. So the other piece here that I think is really important is this: if you put in a real good measurement system, which I've alluded to a couple times, we start teaching the folks on the team how to measure, how to monitor real early on, and you've got good visible measurement systems of all of your key metrics up and down the line, you can have early warning systems in place. So on the left-hand side there, see, it's a permanent habit of measurement. By implementing effective visual management and relentlessly measuring the right indicators, signs of potential problems will always alert team early enough to intervene. So that little graph in the middle is just, gee, we've got some registration errors. And we see it. We're measuring at the registration level. We're measuring that work every day. Let's get in there and fix that before we have a situation on the bottom there where the denials start to go up, right? So there's a little bit of a lag time. And if we've got good measurement, good monitoring, and good attention on the process, then we're empowered to do that. And this is not a Band-Aid approach. So if you make this sort of investment in your people and you teach them how to problem solve and teach them how to see defects, how to measure, and how to monitor, you've set yourself up for the future. You're embedding problem-solving thinking across your team. And that's going to empower them then to understand and solve problems and know that they can, as opposed to sort of feeling a little bit burdened by a system that's not workable for them. And they understand the scientific method. They understand how to experiment with changes and try things before they become permanent. Anything to add there, Rich?
Yeah, no, I think you hit it right on the head. I think, again, so many organizations I've worked with, you're waiting until you see it hit the financial statements before you start dealing with it. This says, let's back it up to the first moment when we can identify it, deal with it before it becomes an issue.
I think one other thing I would say too, and this kind of harks back to the initial slide that showed the opportunity for denials, and that I think it was 20% of them are really truly unavoidable. There's also a way to separate out which ones can we fully control versus which ones do we have to go to a payer and negotiate. We got to negotiate a new contract. There are a lot of things you can do with your team that your team can do that's right in your backyard that will plummet your denial rates. So that's another thing to consider when you're looking at the opportunity. There's a lot you can do without having to kind of be beholden to the right rules coming our way. So I think that's an important point as well. And so, so just a few examples from past clients who've used this approach in revenue cycles, large to small. So we had there was a Midwest academic system here. This was pretty big. They had a pretty expensive cancer care system, and in one particular improvement effort, they managed to prevent almost $270 million a year in denials, and that was a net figure in oncology alone. And so that resulted then in about $4 million a year hard savings to their bottom line, just from the time value of money, because they got paid faster. Separately, they were able to eliminate about $1.6 million a year in write-offs due to denials after the appeals were exhausted. And that was in oncology plus a couple of other inpatient denial types. So the write-offs is a huge portion of the denial problem. And then there's this people piece. They were in the process of eliminating all these denials. They also eliminated all the work that people were doing to fix them. So not only the denials, but many organizations have what's called a scrubbing system that's looking at the claims before they go out to the payers. And that system pumps out a lot of defects into various work queues. And so that was requiring a lot of time too. And so when all was said and done, they eliminated about 10,000 hours a year of staff time. They didn't lay off 10,000 hours worth of people. That's not what that means. That work was spread out over many, many people doing the work. But that work, that time then could be redistributed to more value-added work for the organization. And then below that, there was a national mammography company that did a very focused project on front-end denials, just looking at their top 5 front-end denials. They prevented about $11.5 million a year in gross in denials just because of their volumes. And they achieved those results right around 4 months. And then over on the right, there was a smaller Connecticut hospital. This was less about denials, but when they mapped out their process, they realized they had a gigantic DNFB, so discharge not final billed. And so through some quick and some less quick fixes, they were able to move out $2.7 million in get that out of their waiting to be billed. And eliminate about $4.5 million of claims held back from submission due to defects. So just they found a lot of defects that they fixed. And then the lower right there is a very big Maryland health system. This was more about staff time. They were and the interesting thing here was this system was really just focused on patient access at the time. But when they were evaluating their front desk processes and their access processes, they found some mistakes that were being made in collecting insurance information, and they fixed them, and that eliminated 4,400 hours a year of staff time. So pretty significant gains from having your people look at the process. It's just amazing what they will find. And I think, we have another polling.
Great, thanks, Erin. For our fourth polling question, we have, how sustainable have previous change efforts been? A, we have been established in rigorous metrics and validated our outcomes. B, we think we have been sustainable, but don't have good metrics to demonstrate it. C, old habits die hard. We've reverted to previous performance. And D, not sure. And as a reminder, you do have option to submit questions to the presenters today in the Q&A window in your console. However, we do have a bit of content to cover today, so if we do not have time to respond during the webcast, we will follow up with you afterwards. I'm going to give the Q&A question about 5 to 10 more seconds here, so please submit your answers. And I am going to close the question now. Back to you, Erin.
Okay, thank you, Cole. So a lot of not sure, understandable. There may be some improvement efforts going on that we haven't really connected or coordinated, so we're really not sure what's happening in the different departments. Then some of you have gone into some improvement change efforts, but don't have good metrics to demonstrate it, and that's pretty typical. A lot of times, if you don't have that rigorous measuring and reporting system in place, or some sort of a system of daily management, it's easy to lose, unfortunately, the momentum, because the exciting part for the team is making all the changes, right? And the unsexy part is going back and remeasuring and making sure we stick with it. So yeah, that's pretty typical. Thank you for that. And I think I hand it back to you, Rich.
All right, thanks, Erin. So, yeah, before we get started on some of these details, just want to reiterate, excuse me, your last point, Erin, around some of the different providers where this has really seen a lot of really good success. And I think, this has seen success in, large academic medical center environments, in physician environments, professional fee environments, in community hospital environments, and then in, large health systems as well. So I think a lot of our conversation here today has been hospital focused, but we definitely don't want to imply that this is really a hospital solution or a hospital approach. I think this really is an approach that works for any provider, regardless of your configuration, anybody who sees denials. All right, so in terms of when to consider investing in denials process design, so first of all is the patient piece of it. Again, patients need to come first, of course. We spend so much time investing in some of our patient centricity efforts and things. And, we talked about before how important revenue cycle is to those efforts and how much contact revenue cycle has with our patients. And so, we definitely don't want to get them stuck in the middle and have them be impacted by these denial issues. The next is, if we're planning for a system implementation, I think the best thing you can do in our experience is really have a solid process that you're building upon for that system implementation. We've seen so many times where system A is in place and we try to just kind of band-aid on system B onto that existing process, and it doesn't work. So you really want to kind of have a solid process that takes into account the capabilities of the system that you're moving to before you look at that implementation. The third is system or staffing and morale issues. So staff, they want to be productive, they want to get things done, they want to be successful. If they don't have the right processes in place, if they don't have the right technology in place, they're going to be frustrated. And so that can be one of the warning signs that you see as well, that this should be something on your radar. The next one is, there have been so many transactions over the last several years in healthcare. It doesn't look like it's going to slow down anytime soon, even with some of the scrutiny from the government. And so, we see a lot of combinations of either organizations or combinations of business offices. And so one of the approaches that we see pretty commonly in that is where the quote unquote acquired organization just rolls into the business office of the other organization. And I think what we want to encourage and what we've seen that work really well is if you actually do take kind of the best of both processes and technology environments and try to merge them in a way where you end up with something better than either one was in the first place. The next one is, again, we've talked about kind of the downstream impacts. If you're seeing those downstream impacts actually happening, where you're seeing your final denials increasing, your write-offs increasing, your net revenue deducts increasing, that can be absolutely a sign that this is a problem and you need to dig in and figure out what's going on. And the next one, a lot of times what we see is that providers know that these issues are out there, but people are spread so thin and these issues are so complicated that even when they're known, it can be really tough to get to the bottom of them and fix them. And so, we often see these kind of festering denials issues that are out there. And one of the things that usually tells us is that if there aren't resources to get to these issues that are known, then there probably are others out there as well that are unknown and that need to be dealt with as well. And the last one here is around evaluating technology investment. So, you want to make sure that you're directing your technology investment to the area with the highest need. And really the best way to do that is to understand kind of what the right balance of your people processes and your technology processes should be, so that you can figure out the best value for your technology buck. And then, some of the kind of the bottom line things here that we see, so because, payer behavior and provider financial results are in the peril that they're in, provider organizations really don't have the luxury of not focusing on denial management today. One of the big challenges, we've talked about this, is having your organization try to kind of dance in sync, trying to get everybody to work together on these things. Healthcare is just like unbelievably complicated, right? We all know this. And so, you can't just assume that it's going to happen in sync and your organization is going to fall in line, right? That's just not the way this thing works. It takes effort and it takes a lot of organization to get there. And because so many of these transformations fail, we want to make sure that technology is a key enabler, but we don't really want it to be driving the design of the process. We want to make sure we're cultivating a good relationship with our payers. The further upstream we can go and address these with the payers before they even happen, that's really the best way to do this. And in some cases, that's possible. In some cases, payers don't like having these processes in place either, and so we can reduce some of the administrative spend kind of on both sides. And then, we talked about this kind of top down and bottoms up. So we want to have really strong sponsorship from the top of the organization, and then have it also being driven by a staff who are invested in problem solving. That's really when it works best. And then, because everybody's spread so thin, because these are so complicated, we really do find a lot of times it's a tough ask to have people kind of add one more thing to their plate and get this thing moving. Really, the best way to get this moving a lot of times is by getting outside help to get things kicked off. Erin?
Yeah, I was reflecting on the point you made about payer relationships, and here's a bold idea, and I've actually seen this happen before. If you have members, if there's a particular payer that's sort of at the top of your list for issues and denials and that kind of thing, you can have a team like I described, the mapping team, that has some folks from your payer on it and some folks from your billing department on it. And you would be amazed about the things that they find out. It turns out that a lot of the problems that they have are very similar. And so that can yield some pretty interesting results, kind of out of the box thinking there. So how can I get started now? We always like to leave you with a couple things that you could go right out and do right now if you want to do it. And these are a few that we really believe in. So try choosing just one of your processes. So pick registration or pick pre-auth, and go observe it. Watch what they do and see if you can map it out. Go old school with the Post-it notes. Try to map it out step by step, including the portions that your systems are completing, and see if you can see where might breakdowns be occurring, right? Where are there handoffs there, and are there handoffs always happening, or are they not happening? Where might there be some breakdowns? So that's a good exercise. The next one is go to your denials department and go observe them work their denials and talk to them and ask them questions. Where do you see pain points in your work? Might get some interesting answers from them that you might not already be aware of. Or third there is choose a stubborn category of denials, do some Paretoing and figure out what's kind of your top problem, and do root cause analysis. Maybe pick one denial type and work with your team to challenge them to do root cause analysis. Keep asking why. Keep going back upstream to figure it out. And don't stop until you've identified a true root cause. And usually it's going to be over 4 layers down. We like to say ask the 5 whys. Sometimes it takes even more than that. So those are some good exercises that you can get started with. And I can't stress this enough. When you go watch folks doing this work that they do every day, you're going to learn pretty amazing things. So those are some good exercises to get started. All right. So we have a little bit of time left to look at Q&A. You want to work with me to see if we can get some of these questions answered? I can start with one. Let's see, let me move down. I got to scroll here. Sorry, folks, I'm learning this system. All right, so Deepak asks, what are thoughts about appeal letter writing software as a service solutions? And I can't really speak to that. Do you have anything to add on there, Rich? Yeah.
Yeah. Thanks for the question. So I think, looking at appeal letter writing, that's a great example of something that can be automated, that can be improved by technology, that is not necessarily going to be value add from the folks, from the team members, and that they're going to be thrilled to get some of that moved off their plate, or at least to get it automated and to get the additional efficiency there. So I think having a technology solution around appeal letter writing is definitely in line with what we've seen be successful and in line with the methodology we're laying out here today. So definitely encourage that. One other question I'm seeing from my friend Harold, are we encouraging more regular cadences between Medicare cost report teams and revenue cycle teams? And because, of course, as Harold knows, the Medicare cost report is the center of the universe. And yeah, thanks, Harold, for the question. And there's no question about it that I think the more that we can be, again, emphasizing that systemness between the reimbursement teams doing cost reports and other things within that team and revenue cycle, I think that is a huge benefit. And I've seen situations, and I suspect, Harold, you probably have too, where we actually have team members within, like, say, finance and revenue cycle who have never met each other. And I've brought these teams together. You get people together in a conference room, and we're introducing each other. And I realized that half of the people who are within the same organization maybe sit one floor apart or something like that. Or these days, we're all virtual. But work in very close proximity organizationally, but they've never met, they've never tried to work together. And so, having that cadence and having that coordination is absolutely critical. And I think, we've seen time and time again where when one team can kind of go off in one direction, another team goes off in another direction, it can cause a lot of problems. So thanks for that question.
All right. One of the questions we have, let's see, during the mapping phase, it sounded like we have to map the entire revenue cycle. Is that correct? So what you bring the team together to map is really going to depend on what your data shows you is your greatest area of opportunity. So your data may show you that that the front end is the biggest problem. And that's where you want to have some representation on the team. It may show that you've got a lot of issues in coding or utilization management. Your denials are really around that. And so you might want to bring people in to really focus on that. But what I would say is that in order to get that system view so that people understand the big picture, you are going to need to have representatives from the back end, so from the denial team, the billing team, the folks who are dealing with the defects every day, the appeals team, and folks from the middle and the front of your revenue cycle in the room together so that they can learn from each other. So the cross-functional piece is really important. You may not need every single department represented, but that speaks to the importance of really understanding what your problem is by really doing some deep dive data analysis to find out where your problems are coming from. So that's really important. And I think we are about at time, actually. So let's see. Do I turn it over to you, Cole?
Yes. Yeah. So
right.
Thank you to both Richard and Erin for a great discussion today. I want to thank the audience as well for being engaged and submitting your questions to help guide today's conversation. If we didn't have time to answer your question today, we will follow up with you after the webcast. Also, feel free to reach out to our presenters if you have any additional questions. Their contact information is in your console. There are a number of additional resources in the upper right corner of your user console that may be of interest to this audience, so definitely check that out. And if you met all CPE requirements, your certificate is available to download now in the CPE progress window. A copy will be emailed within 2 weeks should you have difficulty downloading it now. And as a reminder, if you attended today's presentation in a group and would like to receive CPE credit, you must complete the group attendance sheet found in your console. Finally, here is a link to an online survey for today's presentation. Thank you for joining the webcast, and we hope we'll see you again next time. Take care.